I'm attorney Richard Hastings, and welcome to another episode of Justice in Scrubs. I'm joined by my co-host,
Dr. Jeff Michaelis. Hello today.
And today we have the pleasure of having Dr. Joanne Saltis, a community geriatric care provider who does a lot of work with dementia. So welcome to the program.
Thank you so much for having me.
Before we dive in, it's important to remember that the information we provide is for informational purposes only. Every situation is unique, and decisions regarding your health or legal matters should be made after consulting with your own doctor or lawyer. Our aim is to inform and empower, but personal circumstances require personalized advice. We'd like to take a moment to thank our sponsor, findagreatattorney.com. If you or a loved one has been injured in an accident, finding the right lawyer can make all the difference in getting the compensation and support you deserve. That's where findagreatattorney.com comes in. They're a free lawyer referral service that connects accident and injury victims with the best attorneys in their area. With findagreatattorney.com, you can be confident that you're getting a highly qualified and experienced lawyer who will fight for your rights. The best part? Their service is completely free. So you have nothing to lose and everything to gain. If you're in need of legal assistance, head over to findagreatattorney.com and let them help you find one of the best lawyers in your area for your case.
So what inspired you to do geriatrics and palliative care?
So I started off my career as a hospital physician, and then from my experience in the hospital, seeing so many elderly people coming into the hospital, I decided to become certified and learn a little bit more about palliative medicine, which is really, palliative care is really all about caring for people who have advanced disease, advanced illness of any sort. It could be dementia, it could be cardiac disease. And I was drawn to that population because there's just so much need and so much vulnerability, especially for those with cognitive impairment. So I started off in the hospital as doing a palliative care program for inpatients, and then over the last 5 years, I've been focusing my attention on doing home visits, bringing palliative care and primary care into the community.
Can you describe what palliative care means?
You know, I'm glad you mentioned that because it's often confused with hospice care. Palliative care is really about symptom management and support services for those with any type of advanced illness where there's an alteration or a compromise to one's quality of life. So it could be any disease process from cancer to heart disease to lung disease to dementia. And generally, as those diseases progress, the symptom burden is high, and the support needed to not only manage the symptoms, but also to support the patient and the families is there. So palliative care is really all about teamwork to support those with advanced illnesses which compromise one's quality of life.
So one of the things that we're going to talk about today is dementia. Mm-hmm. And many of us have personal experiences with family members that are affected in some way by dementia. So I think the first thing I would like to talk to you about is what is dementia? What is Alzheimer's? What is this whole kind of spectrum of these diseases?
Sure. Dementia is really the umbrella term that basically has under the umbrella various different types of neurodegeneration which lead to loss of brain function. Most of us are familiar with Alzheimer's because it's the most common form of dementia. Probably about 60 to 70% of cases of dementia now are thought to be secondary to Alzheimer's disease. There are other types of dementia, including vascular dementia, which is another more common form of dementia, Lewy body dementia, there's frontotemporal dementia. Basically, all of these types of dementia, subtypes of dementia, affect brain function in different areas of the brain and lead to compromised cognition and functional capabilities.
So why don't you talk about the different areas that are affected, say, if you have Alzheimer's or if you have Lewy body or if you have frontal temporal lobe?
Sure. So with Alzheimer's dementia, the two characteristic areas of the brain that are most typically involved are the temporal lobe The temporal lobe is responsible for our ability to process language. So generally, people with dementia have difficulties with speech. That's one of the earlier signs of dementia. Being able to complete sentences. Memory is also in that area of the brain. So short-term memory is typically very much impaired, much more so than long-term memory. The other area of the brain that's most commonly involved with Alzheimer's is the prefrontal cortex, which affects our ability to do higher level functioning, managing the checkbook, driving to the grocery store, managing the to-do list at home, even sometimes cooking, once the disease progresses. So it's those areas of function, memory, and language that are typically affected by with Alzheimer's disease. The amyloid protein that most people have heard of is thought to be deposited in those areas of the brain that lead to the disease progression. Lewy body dementia is a little different. The protein that's involved with Lewy body dementia is a different protein, and the typical hallmark features of Lewy body dementia are usually visual hallucinations, very vivid dreams that are extremely disturbing, like night terrors, that people really feel are real, delusions in thinking. So it's really those symptoms that oftentimes would alert a provider, a clinician, that subtype of dementia is likely to be the cause if they're experiencing those symptoms. People with Parkinson's disease, they have that same abnormal protein, but it's just affecting a different area of the brain. Some people have both Lewy body dementia and Parkinson's disease when that protein is found in the areas of the brain that cause both the motor involvement that you would have with Parkinson's and the memory involvement that you would have with Lewy body. Vascular dementia is thought to be secondary to alterations in blood flow, so that usually the presentation for vascular dementia is different. People present more like they're having small mini strokes, and over time they have changes in cognition and function due to the abnormalities associated with blood flow to the brain. Vascular dementia is also thought to play a role with Alzheimer's type dementia as well, which is why I think one of the things that's so important for all of us to do, especially, as we're younger and moving on in our older years, is to try to maintain a healthy lifestyle, exercising regularly, moving, making sure that we're eating a plant. I always advocate for a plant-based whole grains diet. Yoga, meditation, anything that would limit stress and promote a healthy lifestyle, I think is really important to prevent any form of dementia these days. So that's a positive thing that I think we can all focus on, just like we would for our cardiovascular health. And then there's the frontotemporal dementias, which are the most common form of early dementia. So it's often sad. I actually had an aunt who developed frontotemporal dementia in her early 60s. She was working in a jewelry store, functioning perfectly normal, in a normal way, and then she suddenly began to exhibit personality changes that were very opposite to what she had been like her whole life. Very disinhibited, impulsive. Those types of behaviors were really like completely opposite again to the woman that I always knew as my aunt. And before long, she was diagnosed with frontotemporal dementia, which unfortunately oftentimes progresses more rapidly than Alzheimer's dementia. So those are the main subcategories, yeah.
Yeah, so last night I was talking about with my friend, and I told him that we're doing a dementia podcast.
Yeah.
And he said to me, he started talking, and he said to me, I can't sometimes remember words. Word finding is difficult. Do I have dementia?
Yeah.
Or do I have age? Or, what are the early symptoms of dementia or Alzheimer's? And what's allowed, like if you're 70 years old or 65 years old, what are you allowed to forget?
That's a good question. I think it's very common. Our brains age in a quote-unquote normal way, just like the rest of our bodies age. And I think it's very common to have those periods where we can't remember a street address or a phone number, or we might get lost in a sentence. But it's really only when the short-term memory affects our day-to-day activities, and when the functional things that we used to do, from getting dressed to going to the store to cooking and all those activities of daily living that we could do without thinking, when those activities are affected by our memory lapses, then that would be the time that I would be a little bit, that I would want to at least make sure that we weren't dealing with early dementia. But it's very, very common for people, as we age, to have what we would refer to as sort of mild lapses in memory. So, yeah,
So
it's very reassuring.
he doesn't need to worry that he's having dementia.
No, but I think it's always important, and now even more so, because almost 7 million people in the United States now have Alzheimer's dementia, and it's expected to triple that over the next 30 years. So it's there, it's in our face all the time. So I think it's important to have routine screening, once a year when we go to our PCP or family doctor, to have them just do a quick mini mental status exam, or a quick, there's a few different assessments that we usually use for routine checks in with physicals and so forth every year. So I think it's good to be aware and to have those checks and balances, but I wouldn't be surprised or worried. And of course, that anxiety often leads to more word finding issues, right? So it's like a vicious cycle.
Right.
And we think we've all been there. So I don't think, but I think it's important to be routinely, screened and have discussions with your primary care doctor.
So that's one of the things I wanted to ask about. So I come in to see you and you're going to do these tests or the screening.
Yeah.
What is going to cause you to say, I think there's a problem here?
A low score on one of the cognitive assessments that I mentioned, either the Fulstein Mini Mental Status Exam, or we use something called a SLUMS examination. And if the score is low and there's no other potential cause for the low score, in other words, I would want to make sure there's not an acute medical illness going on that might also interfere with one's cognition. That's referred to as delirium. Someone might have a urinary infection, for example, and their ability to function, their cognitive function it's not uncommon that might be affected. So if there's no other causes for the cognitive lapse, then I might want to do some more. Then I probably would want to do more testing to see if there's any validation to or concern for dementia.
So are you going to ask me questions like who is the president, what day of the week is today, and questions like that would relate to a lower score?
Yeah, it's similar. These standardized tests have been, validated, and they test not only your short-term memory, asking you to remember a few items minutes later. They would also test your ability to your visual spatial skills by having you, for example, draw the right time on a clock and answer some basic questions after you're given information on a reading, a small reading paragraph. So based on your comprehension and the short-term memory from the assessment, then we would have some information, objective information, then to decide whether or not we need to move forward with more testing.
And then what would moving forward look like?
Usually, the testing usually involves a diagnostic test such as an MRI, just to make sure there's no structural or anything else anatomic that might be causing a change. I think screening for depression is also extremely important, because depression can also oftentimes masquerade as dementia. So I'd want to do a good screening test for depression, and if that's a concern, and also of course ask more questions about whether or not depression could be a possibility, then of course I would want to go in that direction if that was positive. But getting back to dementia, so it usually would be an MRI. There's basic blood work that we routinely do when we're doing a workup for dementia. That would include routine blood tests like a CBC, a chemistry. We'd want to check a thyroid and look for any other anything else in the serum that might be associated with another medical illness that might be causative for the cognitive change that we're seeing.
So you're going to do an MRI, and you're not going to look at the MRI and say, there it is. You're looking to see if there's any structural damage to the brain?
Exactly. It would be really to look for other causes of dementia, and also to see if there's any changes. We might be able to see atrophy and changes even in, if someone has had a number of small mini strokes, for example, that would show up on the MRI. So we'd want to also look for if there is structural damage. Perhaps it's related to vascular dementia, or is there something else going on, like God forbid, a tumor or something else that might be causing it.
And what are you going to find in the blood work that would alert you to a problem?
Thyroid, believe it or not, sometimes thyroid abnormalities can masquerade as dementia, B12 deficiency, folate deficiency. So there's certain deficiencies of even routine vitamins that might lead to issues with cognition. So we'd want to make sure we ruled all that out and get the MRI before. And then the next step would likely be consultation with a neurologist I usually recommend.
We wanted to take a quick break to remind you about our sponsor, findagreatattorney.com. Dealing with the aftermath of an accident or injury can be overwhelming. And the last thing you want to worry about is finding the right lawyer. Findagreatattorney.com simplifies the process by connecting you with one of the top attorneys in your area who specializes in your specific type of case. Whether you've been injured in a car accident, suffered a slip and fall, or experienced medical malpractice, findagreatattorney.com has a network of experienced lawyers ready to help. And remember, their service is completely free, so you can focus on your recovery without worrying about the cost of legal representation. If you or someone you know needs legal assistance, don't hesitate to visit findagreatattorney.com and let them match you with one of the best lawyers in your area for your needs.
Now, does dementia come on quickly or slowly? And what should we, like my friend, he forgot what he had for breakfast or something like that. Mm-hmm. But if something, what should he look out for, like getting worse? I know you discussed everyday living situations and stuff like that.
Right.
But
usually it is, like, especially with Alzheimer's, usually it's a slow, gradual, indolent process and it's usually, that's why it's so important to have information from your significant other, your loved one, your family members, because it's usually the subtle changes of not remembering where your dresser is, like really in that type of forgetting familiar things in your home, getting lost more. I think we all might get a little lost here and there, but really getting lost in a familiar area is another sign. And having those things occur more regularly over time would make me concerned that there might be an issue with dementia.
But it usually happens slowly,
Correct,
right?
It does, exactly.
So there's no hurry to do anything, maybe?
There's really not. I mean, I think, it depends on you too. Like some people, I think, especially right now with where we are, might not want to fully, in other words, know. It really is very individual. I personally think it's nice to have as much information as possible so we could prepare and plan and perhaps treat in a certain way. But you're right. It's more of a chronic, slow decline, especially with Alzheimer's.
And it might even be helpful for someone who doesn't see you very often.
Right.
It's like your spouse or your significant other sees you every day.
Right.
So it might be like when your daughter from California visits you or someone who sees you over a 3 months or 6 month period.
Yep.
That might be more helpful, right?
Exactly. That's true. Exactly. No, that's a good point. And we oftentimes will hear from children of their parents who'll call and say, gee, I finally checked in on mom and the house was a mess and, she clearly is different than she was a couple months prior. So you're right, those changes are a lot probably more easily identifiable when it's, when you're checking in months later and you see that there's definitely been some decline. So that's true.
So one of the things I did in advance of this was I did some research on my own just to get better acquainted with the illness. And one of the risk factors I read about was age. Mm-hmm. So when does that start? Is there an average age when somebody starts to exhibit symptoms? And then when does it become really problematic, just from a kind of a generalization standpoint?
I think anyone over the age of 65, that's when typically we start to see the risk of dementia going up. Definitely over 70, I would say is definite. So I think that should be the age when, with the annual wellness exams, when we're having more screening and more aware, given that we know that the risk for dementia definitely does increase at that stage.
And one of the things we did an episode on the 5 leading causes of death in the United States, excluding accidents. The other 4 all had the same risk factors: being obese, having a poor diet, not exercising, drinking, smoking, and you're saying it's the same thing here.
Absolutely, the vascular, the cardio, like the way we live day to day, it's amazing. I don't know if you've ever heard of Dan Fulstein, but he is someone who's done a lot of research on these areas of the world that have the
blue zones.
The blue zones, thank you, that have the highest number of people who live into their hundreds, who have the lowest risk of any type of illness from cardiovascular disease to dementia. And it's clearly apparent that healthy lifestyle, really, and honestly, I hate to say it, but as much as I think social media and cell phones and computers are wonderful for certain things, I think they've taken away from, the common sense things of just being outside and taking walks, and of course the healthy diet. Our gut health is so important, and I think we oftentimes overlook. We used to think that the blood-brain barrier didn't let anything through, right? But it's clear that there's alterations in our gut that lead to, where our brains are clearly affected by the diets that we choose to take in. So healthy lifestyle is above and beyond, I think, the most important thing that we can do to educate for ourselves and to educate our loved ones and our patients.
And you touched on this, but I read a study from Harvard that said one of the reasons that you will live a longer life is having sustained relationships, close relationships with other people. And you were talking about the importance of, as we get older, to get out and socialize. And I think that's an important consideration to talk about.
It is absolutely so important. Social connections, social networking, our relationships are key. I mean, not only in terms of preventing anxiety and depression as we get older, but also because it's just, we as humans, we need that connection. And I think the limitations, the cell phones, the computers oftentimes limit those very meaningful, important ways to stay connected to each other and to our community. Having
Great
a purpose.
point.
Having a purpose, yeah.
What about the genetic factors? Let's say I have a mom or an aunt or somebody that got dementia at 55. And should I be worried, or does it affect me at all, or is it at a one-off situation?
That is extremely young, obviously, for dementia. There are genetic tests that can be done. So if you would want to know your risk factor status, there's this allele called the apoprotein 4 allele, which can be tested for. And if you happen to inherit one from your mother and one from your father, your risk of getting Alzheimer's disease is much higher, and it's oftentimes diagnosed earlier too. So, so you could fall into that subcategory of having one of the early onset dementias based on your genetic history. So then the question again is, though, how much information do you really want, given where we are right now with treatment, or best just to do everything you can to have a healthy lifestyle, and so it depends on the person.
Let's talk about that, the amyloid genetic testing.
Yes.
So I know there's some new medications out there that address the amyloid situation, and there's some studies that are being conducted presently about the amyloid. So, and also, if you have a first-degree relative that's a little young to get and let's say you test positive for the allele of the genetic testing. What would you recommend? Would you recommend going to a center somewhere and maybe started on one of these experimental medications?
So assuming you have some signs of early dementia then, or
just have a family history.
Yeah. I think the NIH has a wonderful website, by the way, and the Alzheimer's Association as well, for being able to connect people to different centers in this area that really have programs, especially with these newer medications. You need to be attached to a center that where the testing can be done properly and the medications administered. Because I don't know if you probably know that these newer medications have to be given via infusion, at least right now. So there's a lot to the process of really first establishing whether or not you'd be a candidate, and then going through usually PET scans and the infusion. So the good news is that the medications, the monoclonal antibody medications, have been shown to really improve or stabilize the disease progression for early Alzheimer's, not for moderate or severe or later stages. So if you do test positive for the gene, and especially if you have signs of early dementia, it would be best, I think, to go onto the NIH website, and I think either Yale or Columbia, they have probably the best resources in our area, or centers where you could, if you wanted to, at least get all the information to see if you would want to be treated with one of these newer medications.
So why don't we go into the treatment now?
Yeah.
So tell us present day treatment. And then we'll talk about the future treatments.
Sure. So right now, unfortunately, the acetylcholinesterase inhibitors, which have been around for a long time, have not been proven to really alter the disease progression as we had hoped initially. So they might help a little bit mitigate the behaviors associated with, or the changes associated with anxiety and certain behaviors that oftentimes are challenging as the disease progresses. So if they're started early on, there has been shown to be some mild benefit, but not, some people just can't tolerate them because there's oftentimes a lot of GI side effects. So that's the one category of drugs. The other, memantine is the other medication that's been around for a long time. It's an NMDA receptor inhibitor, so it affects inflammation in the brain. But again, it's often used with the Aricept type medications, and there might be some slight benefit, but it's generally not significant. So I think many providers will offer those medications, but with the understanding that, if there's any intolerance or there's no change, then they should probably be discontinued, as assuming that the disease is going to progress.
Yeah. What about the new IV medication or IM medication?
So the one that was just improved, Leqembi, is the newest one, and that targets the amyloid protein in the brain, and it has been shown that's the main one now that's being utilized. It's again targets the amyloid in the brain, so it has to be given by infusion, and you need to again be followed with these PET scans. So there's a lot to it, but it's positive results for those who have just the early form of Alzheimer's disease right now. So I would suggest to go on the NIH website and try to figure out, based on where an individual lives, if they wanted to get further information regarding. And the good news is it's covered by Medicare now. So there had been a big debate going on regarding the finances, because, as you probably know, these newer agents are quite costly. So at least it is an option for those who want to consider treatment.
So do they get better or do they not get worse?
They stabilize. So the data has shown that there's some stabilization, so they don't progress as quickly. It's not a cure again. Unfortunately, it doesn't completely eradicate all of the plaque in the brain, but it does halt the progression of the disease. And typically, I think it's been shown to give at least another year of stability before things change in the latter stages.
Well, the year might be important.
Exactly, for many people. Exactly. I actually have a patient who lives at one of the communities who I go to, one of the assisted living facilities. She mentioned that I could use her name. Her name is Geraldine Taylor. And she is one of these people that I just like. She's phenomenal in that she was a successful nurse. She worked in the city for many years as a public health nurse, and she herself was diagnosed with dementia. She was doing work trying to advocate for those with dementia, and she was diagnosed with dementia in her late 60s. She was one of the first individuals to go on in a phase 1 trial, the older agent that was taken off the market. It's called aducanumab. I have to look at my notes because I could never remember the name. And she actually did get a year of stability. And she and her husband, Jim, again, phenomenal people, they created their own organization called Voices of Alzheimer's. And if you ever have a chance, if anyone goes on the web to check them out, they are just, because what they do is they try to bring the stories of those living with dementia to the public forefront, and they also advocate for newer treatments, including these medications. Jim was one of the people who helped sort of push the legislation through so that these medications could be covered. So anyway, I'm oftentimes taken for people who are stricken by the disease, but yet, despite that, have the positivity and the energy and the will to try to make things better for others who are suffering with the same disease.
So this medication, can anybody get it? Is it hard to get? Do you have to go to a neurologist? Would a primary care physician do it?
You really have to go to a neurologist, and I suggest going to one. That's why the NIH is so helpful, because you really should be at a center like Yale or Columbia to really have the proper screening and follow-up, this PET scanning and so forth that needs to be done to monitor for any side effects. Unfortunately, like with the original agent, there might be a risk of having some inflammation or bleeding in the brain. So that's why there has to be routine PET scans done at different intervals when the medication is being administered. Leqembi is usually given every 2 weeks by infusion. So there's a lot to it, but again, there is some positive a lot of positive so far, I think, at least but it's really just for the early stages. I'm disappointed. I wish that the results were more, promising or could be applied to those with more advanced dementia, but unfortunately, that's not the case right now.
So does Medicare pay for most of it? Or?
They do. They pay. Yeah, it's completely covered if you qualify. If you've been diagnosed with early Alzheimer's, it should be fully covered by Medicare.
So the copays are just your usual copays. It's not anything more than that.
That's right. Even for the PET scans, it's all included. That's why it's good to be at a center.
And you want to talk about the newer medications that are coming out?
Well, that's probably the one that's gotten the most press is donanemab, which is similar to Leqembi, but it's shown more promise in the earlier phase studies to really have even more benefit. So the hope is, and it's actually over the next few weeks, that it's going to be approved by the FDA,
really?
So that it also should be covered by Medicare as another option. I think they're hoping to come up with a subcutaneous so that it can be administered right under the skin, the medication, because going for infusions every couple of weeks is not easy for a lot of people. So hopefully when that actually does, and it's expected to happen over the next few months, then that will, I think, make a big difference for others who want to pursue treatment.
And the mechanism of action is also the same, right?
Correct. It targets the amyloid. Right, exactly. Yeah. And the PET scans actually are able to look at both amyloid and tau protein, the other protein that's associated with amyloid, with Alzheimer's disease in the brain. So that's why having those PET scans so they can monitor to see how much is being, targeted by the medication and or to see if there's any side effects from the drugs.
So you can see actual improvement on the PET scan?
You can, exactly.
Wow.
Mm-hmm. Yep.
Wow.
Yeah, exactly. And pretty soon there'll be biomarkers. They're talking about being able to just, have, in addition to the genetic testing, also being able to test your people's blood for the amyloid and the tau protein so that we could have more conclusive biomarkers so that we'll know, more conclusively if people actually have Alzheimer's and then how best to follow them.
Yeah, so you can follow the number, right?
Exactly.
That's very helpful.
It'd be much better than having the PET scans. Exactly.
Or just using these questions that people can cheat on.
Yeah.
Right.
Exactly.
Right. Because there's some very smart people out there that can cheat.
I know, exactly. So we want to definitely have it more standardized.
Right.
So I wanted to switch gears for a moment and talk about the practical side of this. And I talked to a number of different people before today's show and mentioned that you were coming on. And these are adult children that have elderly parents that are experiencing these issues. So I wonder if you might walk us through some of the things or you would tell them or conversations that you might have, because for many people it's overwhelming.
It is.
And it's almost like a living wake in many instances, in that you have this parent who really doesn't act like your parent, or in some instances doesn't know you or remember you, or so what are some of the things that you talk to these children about?
It's really it is really challenging, and I think having, number one, safety is always, I think, the biggest concern with those who are starting to decline. In terms of wandering, believe it or not, is one of the most common issues with early to moderate dementia. So putting checks and balances in so that your mom or dad doesn't, wander out the house and end up in getting lost or their safety obviously would be a concern as well. So trying to have a support system in place so that safety, nutrition, it really depends on where they are functionally too. There are a lot of resources in communities to help families try to figure out if a caregiver is needed, how to find the best caregiver in a community. So there's a lot out there. It really depends on the need and really monitoring what changes are affecting the individual's life. It's really so variable. It's funny, in the near future, there is I'm sorry, I have to look at my notes for 1 second. There's a program called the GUIDE program, which was just released by CMS. I don't know if you've heard of it. It stands for Guiding and Improved Dementia Experience. And it's a big mission on the part of CMS, Medicare, and Medicaid to allow for more support for families, for children of those who have dementia, as well as for people who with dementia themselves, to really have access to better resources, whether it be needing a caregiver, having respite for a child or a spouse who might be having to care for, because it's, as you probably know, it's exhausting and overwhelming, especially in the latter stages. So I think this program it's the first of its kind, and it's going to be released on July 1st. So I'm very excited that we'll be able to have a whole new network of resources available for people who are struggling, especially if your mom or dad lives, if there's a distance between you. Then, of course, you really need to have people close by who can be checking in, who can be, obviously, are they driving the car? And if so, maybe that has to be, the keys have to be taken away. And who's going to do that? I mean, who's making sure they have healthy, we talked about the importance of healthy nutrition. And even though they're advanced, I think that I can't stand when I go into a facility and I see like donuts and syrup on the, it's healthy eating is so important regardless of what stage. And I think so getting back to everything we can do to try to cushion them, and support them and keep them safe as things change is so important, but it's hard. And I'll often have spouses or children come to me and just say, listen, I can't do this anymore. And people need to know that it's understandable to feel that way, and that there are resources, and you need to oftentimes just take a break, find someone who could sub for you, almost like having a child at home, and you need to just go out on a date night and just get away, because you it's oftentimes day after day after day that caregiving, care partnering, however, that's the new term we're trying to use, is can wear you down. So.
And my dad was in a facility, a convalescent care facility, and they had a dementia unit there.
Yep.
And it was interesting to see the dementia patients because they interact very differently. Mm-hmm. And, they have them in a separate wing where it's locked and they can't get out, and they have to have constant monitoring. And I just know from caring for my father at the later stages of his life, it is exhausting.
It is.
And having the relationship as the child, you're always treated as the child, and it's difficult to say to your father, for example, you can't drive your car anymore because they're not going to listen to you, and it restricts their freedom. Mm-hmm. So the physical part's exhausting, but for me, the mental and emotional part was very, very exhausting.
I can imagine, and that's when I think you really need a good physician, a good clinician who can be involved and say, listen, this is coming from me. This is not your son telling you this, but you can no longer, and take the load off of your need to just be, the son. And
I think to Dr. Jeff's point, we would go in and my father would misrepresent things to the doctor.
Yeah, sure.
So because he knew that if he gave a certain answer that he would be told that he couldn't do this or couldn't do that. Yeah. So I would always say, can I please go in with him while he's in the room, and I'll correct any misstatements that are going on. But, they're smart enough to know that if they give a wrong answer, there are going to be consequences.
Right, yeah. I know, it's very tricky. And you don't want to take away their autonomy, their feeling of control. That's a big thing. And they I'm sure, feel that slipping away with this disease process. So you have to kind of, try to tiptoe around that a little bit. That's the last thing you want to do, is make them feel more like they're losing one more thing, and that, their ability to control their life. So it's very tricky.
Yeah, one of the problems with advanced dementia is personality changes in behavior.
Right.
And there are some good medications for that, specifically for their behavior. Do you want to talk a little about that?
That's an interesting topic, because I have found that I do feel as though for certain behaviors, usually, anxiety or agitation, as we refer to it, there is a time when oftentimes medications do help and are needed to keep everyone safe and calm, but I oftentimes see and feel that they're overutilized. So a lot of my time is spent looking at the medications and trying to figure out, especially as the disease progresses, what can we take away? It's not uncommon for someone with dementia to go into the hospital, which is, it's one of the most challenging areas for them to go in, because, of course, they're going to be more confused, and they might get sedated, and they might get restrained. So they're going to decline. They're going to be in bed more. So, and then they'll come out to their home or to the assisted living, and they'll be on an antipsychotic, and it'll just be continued, and we'll have to. So I think it's important to always look and see, okay, why was this started? Is there, can we deprescribe? Can we reduce the dose? Because our goal is to only utilize the lowest dose possible of any of those medications, whether it be an antipsychotic or an anxiolytic, something like trazodone, which is commonly used. We want to minimize those drugs, but use them, obviously when we really need to. So the monitoring of those medications, I think, is an important thing that I do, and I also collaborate with the behavioral psych department in our area to help me, because sometimes it's challenging.
Yeah, but sometimes the medicines are helpful.
They are helpful, exactly. Right, and so it's just important to always just be revisiting. To you start a medication 3 months later. Okay, do we actually need it? But I agree with you totally.
Especially when they go to the hospital,
Yes.
and they're in a new environment,
Right.
and the hospital doesn't want to put up with that stuff.
I know.
So they may be thrown on a whole bunch of medications. And when they
Exactly.
come out, there might be a different environment.
Exactly.
Yeah.
I'm trying to put together. My goal is to have a network so that when my patients go into the hospital, I follow them there. I follow them if they say they go in and they break a hip and they need to go to rehab. Because it's really important. I think what happens is when an individual, especially with dementia, goes from home to the hospital to rehab, back home again, there's just so many points in that moving around, that medications could be erroneously changed, and then there's of course the functional decline and the overall cognitive decline that usually occurs when there's that type of change. It's really hard for people with dementia to deal with environmental change, as you know.
Yes.
So I wonder if you might have advice for a family member who might be starting this journey.
I think trying to involve involve your clinician, your primary care doctor, whoever it is, early in the process, so that there's routine checks. If you're starting to see changes, then going to see your primary care doctor every 3 months, as opposed to every year, and really talking about the things that you mentioned, really checking in more regularly, having people close by, if it's not you, to monitor the environment, and just be as engaged and involved as possible. And if a person in your family is diagnosed with dementia, then trying to help them, attending doctor's appointments and trying your best to still remain in the role as child, but that's when the need, I think, is to also be an advocate too, and be assisting with the checks and balances that usually is needed at those later stages. So it's really I think being as involved and involving your clinicians and really trying to stay as engaged and connected as possible.
And as
That
a
helps.
child, an adult child who went through this with my father,
Yeah.
And you'd mentioned this earlier, that you don't have very good short-term memory, but you
Right.
have a prolonged long-term memory.
Right.
And we had purchased this book, and I think it was called Questions I've Been Meaning to Ask You, and it's mom or dad, depending upon who you're talking with.
Yeah.
And you ask questions that have to do with their very distant past. Who was your favorite teacher? What were your favorite subjects? Who were your friends?
Yeah.
What sports did you play? Where did you go? What did you do? And it's amazing how engaged they become,
Right.
as opposed to talking about the presidential race or the news of the day,
Right.
or something that just happened, where they either don't remember it or they're not really apt to discuss it. But you can have very extensive conversations about their past.
Yeah, I'm glad you mentioned that, because in my environment right now, I'm trying to have the people that I work with really learn about each person, because it's really their personhood. It's really, and that information about their past is so valuable, because oftentimes as things change, it's the only way to reconnect.
Mm-hmm.
And it's oftentimes those periods where we might have someone anxious or agitated or upset. Instead of using a medication, I found that trying to redirect and trying to reconnect with that individual on something that's meaningful to them from their distant past is so important. It's the personhood. It's that person living with dementia. Yes, their short-term memory is impaired, but everything that makes them your dad or is still there. It's just sort of locked away a little bit. So if we work harder to try to connect and again limit the medications as much as possible, and just because there's still so much value, and you might have a few moments, even though they might not be as many as you would like, where you really feel like, okay, this is my dad, and I can connect, and I feel, and there's meaning to that, and it's I think what people need to hold on to, even though as things change there might be again fewer moments, but they're so valuable. Yeah.
I remember a story when I used to go to the nursing home many years ago.
Mm-hmm.
There was a lady that was a famous piano player.
Yeah.
And I noticed that she was going like this on her legs, and I didn't know what it was, but then I realized maybe she actually is playing the piano.
Right.
So we actually brought her to piano. Now she was pretty advanced dementia.
Yeah.
And she played beautifully.
Mm-hmm.
Because that was her thing, and she still remembered how to play the piano, even though she couldn't remember almost anything that was happening.
Right.
And she was playing the piano all day long, and I thought that was like a tremor or something. I didn't really know what it was, but then we realized it was the piano.
Yeah, that's great. Yeah,
that was an amazing story.
Yeah, music and art, and that's a great story. There's so many other ways, even though certain parts of our cognition are changing, that you can really experience joy and pleasure and do things that make you feel valuable. There was one patient I had who used to be a cleaning person, and so it was important for her to make sure that the couches and the chairs for all of us when we came in were clean and taken care of, and we appreciated it, and she had a job to do, and it all kind of worked. I think just finding those ways again to make people make those individuals who have dementia feel useful and productive and connected are so important as the disease changes.
And we were talking earlier about the fact that I have a family member who was a chef and is now living in a convalescent care facility, an Alzheimer's dementia facility. And although he's a resident there, he cooks.
Really? That's great.
And he helps serve the food. And the real funny thing is that the staff and the employees there treat him as an employee. So he has this purpose while he's there.
So great.
And it's something that allows him to connect with who he was and what he did. And, he's always tired because he's working all the time. And, it's just such an interesting, dynamic. And with my father, he loved, his favorite song was Moon River by Andy Williams. And so whenever he got a little agitated, we would play that. And it was like magic.
That's so great. That's why right now when I meet a new person who has dementia and I have very limited medical information, I'm more concerned about their psychosocial history for those reasons, what they did for a living, what they enjoyed most, and because that is much more valuable than whether or not they had their cataract surgery done a few years ago when you get to that stage. So that's really it's a great story, and it's so important.
And I think the other advice perhaps to family members is be prepared to be very patient.
Yes.
Because it tests you in so many ways.
Right.
And there's so many things that are repetitive and the same questions and the same issues and the same things that come up.
Yeah.
And this is the end of their life. So you have to make the choice that you're going to make it the best that you can make it.
Exactly. You bring up a good point about as we as people progress toward the end of their life, the importance of trying to do advanced directives early on so that we know when mom or dad or whoever gets to that point what their wishes were when they could make those decisions for themselves. So as a palliative care clinician, dealing with so many people with dementia now, it's something I think so important, and to remind our audience that it's important to do advanced directives when you have your faculty so that you can say, okay, I really, I would never want CPR, or yes, I would want a ventilator, and so that your autonomy is preserved, and that when the time does come, your wishes can be properly
and to have a power of attorney executed so that you can have their affairs managed, much easier.
Exactly. A healthcare representative and the living will are part of the advanced directive that we deal with, where you don't need an attorney, you just need to have it co-signed or witnessed, but a durable power of attorney for healthcare, for finances, and for other legal matters, you would need you.
And one of the reasons we do these podcasts is to educate the public on issues that affect many people. And the information that you provided today has been amazing. And I think it's going to help a lot of people that are going through this journey right now. And we just want to thank you for spending time with us today.
Yeah, thank
so
you.
much for
You were
having me.
great. Thank you.
Thank you. I appreciate the opportunity. Thank you so much.